It's very important that you have local support from a local representative, and they give you that connection with the company. They give you that sort of touchstone in terms of what the company's values are, but particularly if you have questions, if you have problems, any issues with supply, a particular product that you can't get. I found the local rep to be really, really helpful. The other thing is when there's new products coming out, they come to you, they give you the information, and I really like that personal connection and that personality that you get from a representative. I use microthane implants in different circumstances. The traditional way people tend to use them is in revisional surgery, and in my NHS practice I sometimes see very complex revisions, and the polyurethane implant can be really useful after radiotherapy or repeated capsular contracture stuff. But the other time that I tend to use it is in patients who perhaps have a poor tissue envelope, and I'm concerned over time that they're going to bottom out. And it gives me that control that I want sometimes, particularly the position of the nipple areola complex, and I find it particularly useful then. I'm often asked about different types of implants and implant surfaces. Patients can find it quite confusing at times. So I try to make it as simple as I can. There's this decision about shape and projection. So I will tend to show them a typical implant. So this is a silicone gel implant, but one that has a micro-textured surface. So I show it to them, allow them to feel it, and they can sense then just what that feels like, and I explain why it's good for reducing capsular contracture. The microthane implants, which have the polyurethane coating on, patients often like to touch these as well because they have that sort of fairy feel to them, and I explain how there are advantages with this in terms of positioning and the long-term stability and the reduced risk of capsular contracture. My default implant tends to be the mesmo or micro-textured surface. I like this because it's got ease of insertion. The microthane coated implants tend to need slightly bigger incision and slightly more manipulation. For a patient who has an uncomplicated and primary augmentation, then the mesmo-sensitive implant is a good option, and the texture prevents rotation, and I haven't seen any problems with them in the long term. I've been very happy with them. The main factors that influence my implant selection are probably, number one is safety. Because of the recent scandals that we've heard about, and safety is top of the agenda for many people. So I know that Polytech have a good warranty that they have with their implants, that they have very high quality. So I want to know that I have a quality implant. I want to know that I have the backup from a company if there are any problems. I also put people on the NHS implant register. So those factors are the safety side of things. Then after that, it's the range of implants. I want to know that I have a company that can deal with all the situations that I may come across. People think that breast augmentation is a straightforward operation, but there are many different factors and pros and cons. I know that by using Polytech that I have lots of different shapes, lots of different textures, and I've got something to do the job that I need. If a patient has a complication after a breast augmentation, and thankfully that is a very rare event, then I want to be assured that I have the backup of a warranty. And with Polytech and Q Medical, I know that I have the warranty that comes both from the implant manufacturer and the distributor, and this gives the patient great reassurance. They get £1,500 towards surgery on each breast if they have complications such as seroma or bleeding. Seroma is just a fluid collection, or hematoma will be blood around the implant, and that gives me great reassurance as a surgeon and also for the patient in their care journey. The advice I give to patients when choosing a surgeon is to do your homework. You really need to look into the background of the person that you are putting your trust into. And with the internet now, it's possible for you to check their qualifications, to check their NHS work that they do. They should be doing similar work in the NHS. They should be affiliated to the national organisations, that's BARPS and BAPRAS. You can check all of their reviews online. But the thing I would say is to trust your gut. If you go and someone is pressurizing you, trying to push you, trying to give you something and not listening to you, then don't go with that surgeon. You can always walk away, always be safe. The advice I give to patients to ensure about which implant is that they need to weigh up the pros and cons. And generally what I'll do, I'll talk to them about the top 3 pros and cons. And patients often come in with lots of different questions, and they often think, over the muscle or under the muscle is better, and they can be quite fatigued by the end of the consultation. So I will write to them with all of the pros and cons of a particular surface. I will then ask them to maybe submit questions to me via email, and then I bring them back for a second consultation, and we go through those things one by one and come to a joint decision. The sort of tools that I use when supporting patients in size and shape decisions are the latest technology. I use Chrysalix software, which is a 3D simulation software, and since I brought that into my practice, it's been really, really helpful. The patients really like it. There's an adapter that goes on an iPad, their body is scanned in, and then I'm able to simulate different sizes, shapes, under the muscle, over the muscle, and that really helps people visualize how they're going to look, and it means that they can pick an implant that gives them a result that they want. The way you manage a patient's expectations when they're on a journey for breast augmentation is key to their satisfaction. Patients often come in showing me pictures of how they want to look, and with their starting point I know that they will never get there. So I try to do everything I can to give them realistic expectations. So I will show them pictures of patients before and after, and you try your best to find somebody who looks like them, but it's very difficult. I will ask them to look on websites to try to find before and after images of patients who look like them. And I'll ask them to come in and show me what is their minimal acceptable result. And if I know that I can exceed that, then I know that that patient is going to be happy at the end of their surgery. There are a number of women who don't undergo reconstruction after mastectomy, and the reasons why are quite complex. I see a lot of patients in my practice who come after breast cancer treatment, and at the time of diagnosis a woman is hit with such devastating news that it is very difficult for them to think clearly. They are in a mode of survival. Will I live? Will I see my children grow up? And so thinking of reconstruction at that time is either too much to think about or feels like a selfish thing to think about. Once a woman's been through the treatment, once they've come out that other side, they get to think about how they want to live, what sort of quality of life they want to have. And then it's different. Then they want to feel like they're complete, feel like they're rebuilt, feel like they can claim something back of their lives. It's very important that women are given all the information that they need and that they are supported in these decisions. I think surgeons are one part of the team that should be there to inform breast cancer patients about what's available to them. Breast cancer is now managed by an MDT, and there are so many people involved: oncology, radiologists, breast care nurses. Everybody in that team should have all the information and should try their best to give unbiased opinions and information to the patient. Surgeons will be inherently biased as well in terms of the techniques that they know, that they favour, that they are able to offer. So it's really important that the patient has an overview and a perspective on what's available to them, and that they have time to make the right decision for them. The options for breast reconstruction have expanded over the number of years that I've been in the business. You tend to divide them into those that involve using an implant and those that use only the patient's own tissue. As a plastic surgeon, I tend to favour those that use the patient's own tissue. Long term, they have very few complications, but they have a big investment up front, and that is what I tell my patients. If you're going to have major microvascular surgery, then that's a huge investment up front and a long recovery. The corollary of that is that you can have implant-based reconstruction using surfaces called dermal matrices, a kind of artificial skin that can cover the implant, and that can be a relatively quick recovery and can lead to very good outcomes. All of these options are out there, and it's really important that patients get lots of information, that they meet patients who've been through that journey and therefore can make an informed decision that's right for them. In my practice, I see mainly patients who are having delayed reconstruction. A lot of that is due to local setup. If you work hand in hand with the oncologists and the breast cancer surgeons, then you will tend to see a high volume of immediate reconstruction surgery patients. So mainly I see the delayed people, and there are some advantages to delayed reconstruction. Patients have time to think things over, they have time to weigh up information, and the rates of satisfaction between those two groups of patients can be quite different. There are differences between immediate and delayed reconstruction, not just in the timing of the surgery. The differences are in expectation, and the key thing in all surgery is a patient's expectation. If you go under anaesthesia with your own breast and you wake up with a different breast, although that may be a very good reconstruction, it will always suffer in comparison to what you had before. However, if you are a delayed reconstruction patient, these patients come with nothing, they come with a scar. When they get a reconstruction, they are comparing it with nothing, and therefore their expectations tend to be lower initially, and their satisfaction long term has been shown to be higher. It's up to you though to make the decision about what's right. There are numerous factors to consider as a surgeon when you're advising patients about reconstruction. Now, there are sometimes patients who come through the door who are quite clearly very suitable for a particular operation, and those that are clearly never going to be suitable for that. And by that I mean patients who are not particularly fit or have a number of other problems with their health. They can't go through long surgery, they can't go through long recovery, and therefore that strictly limits the sort of choice of procedures that they can have. The other factor is a patient's beliefs. Many of them will come in and they will have very strict ideas that they don't want implants, or that they do want implants and they want minimal scars. And all of these complex factors need to be brought together to come to a decision that's right for that patient. There are numerous lifestyle factors that you have to consider when patients are undergoing breast reconstruction. Some patients come and their overwhelming priority is that they have one procedure, that they're not coming back for multiple visits, and they will be happy to go through what is a long operation, a complex one, if they know in the long term that that's going to be it. And they say, "Doctor, that's all I want." But there are other patients who are perhaps not very fit, and they have very limited options in what they can have for a breast reconstruction. And I have operated on patients who are 73 who come back 4 or 5 years afterwards, and they want a reconstruction. So it very much has to be tailored to that individual patient, their needs, and as long as they know all of the pros and cons, all of the risks, and they're making an informed decision, then I'm happy to support them on their journey. The management of breast cancer now is very much a multidisciplinary approach, and that's how it should be. Any woman who has a diagnosis will come through a really large team, all working to try to get them the best outcome. So there will be from the screening, when many breast cancers are now detected by screening, so there'll be the screening service, the radiologists, the supportive breast care nurses, surgeons, oncologists. They are all key in supporting that patient, in informing that patient, in making sure that what is a huge amount of complicated information at a really difficult time is presented in a way that they can digest and they can make the right decision for them. When a patient comes to me to discuss breast reconstruction, then there are a number of things I want to get out of them. And there are several recurring questions that I will ask. The first thing I'll want to ask them is, what do they know about breast reconstruction? Some women come with no knowledge whatsoever. Others have got very fixed views. They've seen lots of patients who they've been through therapy with who've had particular types of reconstruction. I'll then ask them about their their feelings about implants. Some people are very opposed to the use of implants. They have very strongly held views. I'll ask them how they feel about additional scars. I'll ask them how they feel about long and short recovery times. And I'll ask them what they want at the end of their reconstruction. That's the key thing. And through this process, then we get to a point where we understand each other and we know what the right thing for them is. The most frequent questions that I get asked by patients when they come to talk to me about breast reconstruction, they tend to revolve around length of surgery, the recovery, the potential for the need for further surgery and revisional surgery, or problems maybe with implants down the line. People want to know what the process is going to be over time. They want a vision of how long they'll be operated on and when they'll be back to normal life, and what they're going to need in the future. Breast reconstruction is a complex and emotive topic, but with the internet, with the amount of information that is available, then you as a patient can do your research. You can find out what is available. You can go well informed. You can go with a list of questions to your surgeon. You can ask them what is available, what's the best thing, what have they done the most of, and you've got to make sure that you get the information you need. There is variation across the country, there is variation in availability, and you need to empower yourself with information, with a belief that you should get the right operation for you after breast cancer. It's so important.